So there may be some unusual causes. Most of the time we may overlooked, and with a very successful surgeries also, sometimes there may be a failure. What are the causes? It's not moving. Not showing on the screen. That's why I told you to come early to save time.
Hello, Sam. Please help.
Not connected. Huh? Okay, now it's fine. So this is just a nutshell on here. So we can look. There may be some causes in punctum. There may be following injury. There may be scarring. That's another point. There may be a scar also in some areas. And another important is the membrane. Membrane over the in between the canaliculus, common canaliculus and the sac. Following repeat infection, suppose there is a history of cellulitis or acute necrocystitis earlier, in such cases there is. Those are the, if we can do a very successful this year, there may be failure. Through endoscope, if we do the surgery, maximum the surgeons are doing now in an endoscopic, then also there is just chances of failure. And those are uncommon. I am not moving. Not moving. Not moving the slides. Hang, I think. So this is very, most of the time we may overlooked. There is a punctum. In the punctum the ilices, because one ilices is generally pointed, or that root is generally bigger. So if it is in reverse direction, it's enter little bit, or it may be go up to that punctum also. That's another cross. In my career till now, at least I remove 6 or 7 ilices from the punctum, and as it is almost, it was touching the other punctum, is erode the other. There is some punctal inflammation in the other, and there is epiphora. And the patient was doing syringing to the lower punctum. He was treated, and it was not properly taken care, and that's the cause that foreign body, the ileus is one of the foreign body in the upper punctum, is erode the lower. So be careful on such cases. If you doing syringing, maybe patent to the lower, there may be a cases, and patients are even treated by glaucoma, steroids, so many things. But that simple thing, you just look carefully, remove it. Sometimes it may be very, very difficult to see. You just with the baths you can clean and you can see the ilices. So very interesting case of this lacrimal sac. Is it referred to me for a lacrimal sac mucocele? But there is no history of Epiphora. When I asked, I did all my previous speaker mentioned there's we can go for those diets, etc., etc. Even syringing was done for confirmation. It is the things. Then I realized something is there. Just a send for CT scan. Radiologist again mentioned necrocystitis. What to do? So then I inform or do the syringing. Just introduce a probe inside, and inside. In such cases, you can go here necrocystography. Otherwise, no such situation. Thus, So just I explore the own. Just I thought it may be some lipoma or something like that, the growth. So I just exercise like any DCT kind of thing and remove it. It is just like a one in toto mass. Next I once I remove it is a in toto mass. In toto mass. So then I was in, it's not a lacrimal sac, of course almost sure. Then I just cut in the OT, inside the OT. One moment I cut, there is a worm. And if you look, when I transfer it to the bowel, it is moving. And just it is confirmed, it was a thalassia, very, very rare. It was published in IJO also, it's a thalassia. So, although this is a mandatory, if you are a little bit in suspicion, then you can send toward histopathology, and at least before sending, you can cut also. You can cut, and with a direct illumination, you can see the gross examination. This is our part, because I did the gross examination. That's the reason I can publish. Otherwise, if I not do that gross examination on the table, so pathologist again tell is a inflammation. So finish. There is a sometimes nevus, very big, rapidly growing nevus. What to do in that? It may be a Epiphora also. So my take-home message in such a thing, if there is there, so always use probe. Again hang. Is loose, and so then you can introduce the probe and you can dissect carefully and intubate. Like in a canalicular injury, you can intubate for a moment. Once the granulation starts, then after 6 you can remove. The same thing is in the growth again. What is the method to remove the growth is in the video I am showing, not a good quality video in my mobile.
You can just click on that.
Yeah.
Thus you can click.
So just remove step by step little bit, and then don't pull as a whole. It is just maybe stuck somehow because of that quality of the computer, I think. So you can remove, and then you can just wait for a moment. Then you can observe under the microscope, and if required, you can use a mitomycin. There is a granuloma may happen like this.
It's not moving.
It's not moving
Video
at all.
is not. You can just show from the outside of your.
Okay, outside I will show the video, and repeatedly I will finish it all. So then we can look the punctum. If any suspicion, then with the wood hole pull tool we can do the thing. And as I mentioned, if there is a scar, so there is a endoscope is there. If there is a endoscope is there, we can do with the endoscope, lacrimal endoscope, but it's very, very costly. So that's the reason you can just different probe, you can pass it, and after that you can intubate it. This is one of the options. Next is that how we can tackle the membrane. If there is a membrane, if we do a perfect DCR, maybe by through endoscope or external, there may be chances of failure if we do not remove the membrane. In my video, I will try to how we can remove the membrane and how we can identify. This is basically in a common is if there is a history of cellulitis earlier. In such cases, so moment we can just go ahead with whatever endoscopically or externally you can go ahead as like you can just remove. Then I will show you the next thing. You can prepare the, if you want a single flap, you want a double flap, whatever flap. Now few surgeons are doing triple flap. That's not the issue, but you just exercise, and if you look carefully, the inside the sac inside is not so, that is a whitish membrane like thing. It is here, it is visible, not on the screen is not exactly visible, but here it is means that is a whitish membrane kind of thing, is whitish, not so much. So that's the suspect, and then once I probe it in between the common canaliculus, and there is a sac, there is a membrane is there. That membrane you should remove thoroughly. With intubation and after doing the surgery, it generally retract, but it may not retract also. In such scenario, then if we can remove nicely, then it can be done. So this is the three few points where those are hidden causes, and if you are doing in a under loop, you may miss those type of membrane. If you can remove that thing, then it will your success rate as equal as this. So there is a appeal thing up under appeal free, and then I just want to show you my another video where I just punctal growth. If it is work, then I can. There is some. Here it is PLC media is I think not available. Oh, is already closed. Can you open it up? Just connect it, that video.
How are you?
Very nice. How are you?
Fine.
This session
Best of the best
exhaust
scissor you can use, just hold.
just
This on the
requested them
punctum.
to speak a little bit.
It looks like on the lid, but it is not. It is growth from the punctum.
Just finished my task.
Then with a penis, you just try to locate, and with a very blunt dissector, and in this particular area, just avoid any bipolar or monopolar cautery. Moment you can use any cautery for the bleeding, there may be a scar for permanent. That's why very carefully, like we are doing in cataract surgery, capsular access, then you can try to slowly, gradually pull it out, and there is a bleed. Moment you can pull it out, there is a bleeding. Don't be panic, because from the base, once you can remove the base, there is a bleed. Then you can, with the help of the bath, you can press for a moment, and you can use mitomycin C, because in once there is some growth, I don't want to put any intubation. That's why, as it is in. So if we can control, now the punctum is facially visible and bleeding is reduced now. So just wait few minutes to stop the bleeding. Again there may be bleed, again you can wait, and once it will be totally stops, then till now you can just press it, or you can, once it stopped, then you can use the mitomycin C. That's a very good results. Thank you. I just finish early little for that interaction. Now I request Dr. any query on that?
Yeah, just what was the, you sent for HP?
Yes,
What was
yes.
the
It was a granuloma.
granuloma? Okay.
Papilloma.
And anybody from you have come across dacrolith? Because I got one patient who had dacrolith constantly collecting in the canaliculus. So in that case, what would you like to do?
And in dacrolith, generally in a long-standing cases, repeated attacks of the chronic dacryosis stage, but in this particular patient there is no such stage. It's a gradually increasing in size. Patient observing, intelligent patient, consulted several places, and everyone talked there is something in the punctum, so there may be. But I explain, you will go for that, and we do the biopsy, and then this biopsy confirm it, and then main thing is that it's still patent without intubation.
Sometimes granuloma gives lot of bleeding actually.
Yeah.
Bleeding, that's why.
Pedunculated,
Yes.
that's why.
That's
it
why
was
wait
one
lots
vessel.
of time, lots of time. It may be, you may wait even 5-10 minutes, whatever, or then generally it stops, but it may bleed. Just I request my next speaker, Dr. Nilanjan, to speak on this, because it is in maximum number of patients are in a community-based patient. In our, we are facing that disease profile is not in a higher socioeconomic group, because of the lower socioeconomic, because of the poor quality of hygiene and the diet, or so many things. The environment may be one of the factors, and it is not, we neglected also. There is a two reason. One is a retrograde and an integrated infection. In both the integrated and retrograde infection from the surrounding is very high in case of a lower economic